Good evening, dear doctors. So let's continue our discussion on further OSCE question. So today I planned to discuss OSCE questions from clinical examination of children, and we call that propedeutics of childhood disease. Okay, that is another term for basic information regarding the symptomatology and physical examination of children. Okay, it's called propedeutics. So let's solve some of the OSCE question, means some pictorial form, some x-rays, some clinical correlates or something like that. So let's start. The first one is, look at this. What are the types of coarctation of the aorta and what are the x-ray finding in coarctation of the aorta? Now you can clearly see there are three types of the coarctation of the aorta, but we want the name of those type. Okay, so what are the types means we want the name. So A is, see this coarctation of the aorta is present distal to the ligamentum arteriosum. This is ligamentum arteriosum, and this ligamentum arteriosum is developed from ductus arteriosus. Okay, everybody know that. So it is distal to that. So this is called postductal. Okay, coarctation of the aorta. Then this is the ductus arteriosus. Okay, DA, ductus arteriosus, and this is preductal coarctation of the aorta, and C is called juxtaductal. That means right at the place where there is ductus arteriosus, juxtaductal, or you can also say ligamentum arteriosum. Okay, so these are the three types. This juxtaductal is the most common one. Now what are the x-ray findings in coarctation of the aorta? For that I want to show you another slide. Now you can clearly see here what are the x-ray finding. The number one is, see this, there is 3 sign. Okay, sign of 3, you can say sign of 3 on chest x-ray, number one. And number 2, you can see notching of the ribs. Okay, this rib notching is because of development of the collaterals. Okay, and collaterals are developed between the proximal end of the coarctation and the distal end, so that they will maintain the proper blood flow. That is the main point here. Now what are the other important features of coarctation of the aorta apart from this? Okay, the other features, a little bit of more information, the other features are, there is concentric left ventricular hypertrophy. It's an important point. It is a pressure overload condition, that's why left ventricle will be concentrically hypertrophied. Okay, when we auscultate the back of the child, or the back of the chest, you can say, there will be continuous murmur like sound. Why I am using the term murmur like? Because it is not actually produced from the heart valves or from the heart. It is rather because of the flow of the blood in those collaterals. So this is turbulent blood flow through the collaterals. Okay, so these are some of the important findings. Let's move on. Now question number 12. Okay, identify the developmental milestone which is shown in the picture and at what age it is developed. This is a favorite question from the developmental milestone or development of a child. Now this is called pincer grasp. Okay, now there are two types of pincer grasp. One is called immature pincer grasp, and second is a mature pincer grasp. This looks like quite a mature type of pincer grasp, and this mature pincer grasp is developed at 12 months of the age. And this immature pincer grasp is developed at 9 months of the age. Okay, 9 months of the age. So this is a favorite question. Okay, so please memorize it. Now another question number 13. So what is this condition? Look at the position of the patient in which the patient is lying, and the patient is having trouble to breathe when lying down flat on the bed. So this condition is known as orthopnea. Okay, orthopnea, don't forget. And if the same condition develops in the middle of the night or during the night time, and if it is intermittent, you can call it PND. Okay, PND. What is the full form of PND? Paroxysmal nocturnal dyspnea. Okay, now explain the pathophysiology of this. If this question is asked, then it's quite easy for you to explain it. Okay, now remember, when we lie down flat on the bed, there will be increased venous return. The venous return is increased. So already there is too much fluid collection inside the lung. This is the case of pulmonary edema. So when the increased venous return occurs to the right side of the heart, all that blood will ultimately go to the lungs, and our lungs will be handling more blood. So that will aggravate the situation, and the person will have shortness of breath. Now to avoid this, the person will attain the propped up position, okay, with the help of pillows, or the person will sit on the bed or even stand up, so that the gravity will come back into the picture once again, or there will be redistribution of the fluid, so the person will feel better. Okay, so let me repeat again. There will be redistribution of the fluid, which makes the person feel better. Okay, and when the person lies down flat, there will be more venous return towards the heart. All that blood will go to the lung, and then there will be difficulty to breathe. Okay, so this is the pathophysiology. And another important information, in which condition it is commonly seen. Okay, your answer will be left ventricular failure, which can lead to pulmonary edema. Okay, don't forget that. Now number 14. Now see this, look at this physical examination finding or sign. So you all know this is edema. Okay, it is clearly written here. This is a pitting type of edema. So what are the 4 causes of pitting edema? One of the favorite question, So the 4 causes of pitting edema. Okay, now let's talk this in the next slide. The 4 causes of the pitting edema. Okay, a lot of the causes we can highlight here, but the 4 causes of pitting edema. Now, one of the important causes is congestive heart failure. Second is cirrhosis of the liver. Third is nephrotic syndrome, which is a type of kidney disease, nephrotic syndrome. And fourth is called protein losing enteropathy. Okay, protein losing enteropathy. Okay, so the person is losing protein from the GI tract, which will lead to hypoalbuminemia, and that results in decreased oncotic pressure, and as a result of that, excessive edema formation. Okay, now the second question here, what are the cardinal features of right-sided heart failure? Now, quite an easy question at this level. The 4 features of right-sided heart failure. Okay, right heart failure. Number 1 is raised JVP. But dear students, please remember, in a very small child, okay, because of the short neck, we cannot really examine the raised JVP, but it is always there. Okay, it is difficult for us to examine. That's it. Number 2, okay, there is congestive hepatomegaly, and this is tender liver, which is a very, very important sign of heart failure in children. Probably this is the most important sign in the heart failure in children. Okay, number 3, you can say ascites, excessive fluid collection in the peritoneal cavity, and number 4 is pedal edema. That's why this question is asked here. Okay, these are 4 cardinal features in case of right side heart failure, both in children and as well as adults. Let's move on. Now another is question number 15. So here the question is, what is this deformity which is shown in the picture, and what may be the cause for this? Now see here, this patient is having bulging of the chest anteriorly. This is bulging of the chest anteriorly, and the name of this condition is known as pectus carinatum. Okay, pectus carinatum, also known as pigeon chest. Pigeon chest. Now sometimes it may be congenital, sometimes it may be congenital, or sometimes it may be due to rickets. Now, rickets is caused by vitamin D deficiency, and in rickets, most of the bone becomes softer, okay, and wider, and this type of deformity can be developed. Okay, so pectus carinatum. Now another condition which is actually not similar, but it is a deformity of the sternum, and that is called pectus excavatum. That means the sternum is depressed inside, and this is also known as funnel chest. So sometimes that type of picture is shown to you, and they will love to ask that type of question. Now number 16, you can clearly see the question here. What sign is this? Now look at this picture. This is called Samrat sign. Okay, Samrat sign. Now what is the Samrat sign? The Samrat sign is done in case of clubbing. Okay, I mean whether there is clubbing or not, whether there is earlier feature of clubbing or not, we do Samrat test or Samrat sign for that. And see this, in a normal case, there is a diamond shaped space formed when we oppose the two nails of the two fingers here. But in case of early phases of the clubbing, this diamond shaped space disappear. Okay, there's no diamond shaped space. This is called Samrat sign or Samrat test. Now write 4 causes of the sign, means 4 causes of the clubbing. Okay, 4 causes of clubbing. So this is clubbing, and they are asking the 4 causes of this. Now there are lots of causes of the clubbing, right from the respiratory diseases, okay, cardiovascular system disorder, okay, GI tract disorders, okay. So we'll probably list one after other, okay. In the next slide I will do that. See here. So from the respiratory system, dear students, in case of pediatric age group, okay, these are called suppurative lung disorders like lung abscess, bronchiectasis, then empyema, and even cystic fibrosis. Okay, it can occur in adult as well. Another disease which is very prominent in adult, especially the older people, is bronchogenic carcinoma. In adult, in older people. Okay, sometimes the fibrocavitary tuberculosis can also result in clubbing, and clubbing is because of the chronic hypoxia. Okay, now from the cardiovascular system, you can remember infective endocarditis as the cause of clubbing, and one more is cyanotic congenital heart disease. Now whenever the term cyanotic congenital heart disease comes, you'll always remember the 5 T's, okay, as the cause. Quickly this type of questions will be asked to you. So what are those 5 T's? Number 1 is tetralogy of Fallot. Number 2, transposition of great artery. Number 3, total anomalous pulmonary venous return. Number 4, truncus arteriosus. And number 5, tricuspid atresia. So these are the questions which will be asked to you very commonly, and these are the answers for that. Okay, and from the GI tract disorders, we can remember inflammatory bowel disease like Crohn's and ulcerative colitis, and there is biliary cirrhosis. Biliary cirrhosis. Now these are some of the very catchy questions. Okay, so please try to repeat it. Let's move on. Number 17. Now here there is one picture of the breath sound. So which type of breath sound is this? Now see the hallmarks of this breath sound. Both inspiration and expiration, okay, look a little bit of loud intensity, and there is a clear-cut gap between them. There is a gap between them, and inspiration and expiration are equal in length. Okay, so this is a clear-cut, okay, case of bronchial breath sound. Bronchial breath sound. And remember, write two causes of it. That is the second question. Now if this question is asked, you can say the bronchial breath sound is most commonly heard in a case of consolidation or pneumonia. Consolidation is called pneumonia. Okay, especially in lobar pneumonia, it is very commonly heard. Another condition is, okay, collapse of lung, okay, with a patent bronchus. Patent bronchus means bronchus should not be completely obstructed. Then only bronchial breath sound can be heard. Another one I can mention here is at the upper level of, okay, pleural effusion. Upper level of pleural effusion. This type of bronchial breathing is called egophony. Okay, egophony. So in some other classes or the topics, we'll talk in detail about them. Okay, now number 18, very important question, dear student. This question is regarding the Apgar scoring. So see there, a baby at 1 minute of the birth has blue hand and feet. So this is appearance. So how much score you want to give for the appearance? Blue hands and feet means the central part of the body is still pink. That I will give a score of 1 here. Okay. Actively crying. Now, this is respiration. If actively crying means I will give a score of 2. So this is respiration. Okay, a score of 2. Moving his extremities quite well, a score of 2 again. This is activity, a score of 2. Heart rate 110 per minute. This is pulse. Okay, again a score of 2. And is pulling away from the stimulus. Is again a score of 2. This is G or grimace. So what is the maximum score here? Okay, it is 9. See this? The score is 9. So this is the correct answer here. So please practice this type of question quite often. Okay, because they may change the different clinical scenario to you and ask how you calculate the Apgar score. Okay, so Apgar score is always done at 1 minute and 5 minutes of the birth. And 1 minute Apgar score, they will ask what is the utility of 1 minute Apgar score. So dear students, please remember this. 1 minute Apgar score is for the resuscitation of the baby, whether it is necessary or not, right? If the Apgar score is very low, for example less than 3, we definitely start resuscitation. And 5 minute Apgar score is to check whether the baby is stable or not. And 5 minute Apgar score should be more than 7, then we say the baby is normal. And remember one more thing, it should be repeated until and unless the 5 minute Apgar score is, the Apgar score is more than 7. What I mean is, even after 5 minutes, at 10 minutes, you have to repeat the Apgar score if it is less than 7. Okay. Now, question number 19. Identify the white substance covering the newborn baby. So you can clearly see a newborn baby here, and this white sticky gelatinous substance, white sticky substance is covering the skin of the baby. Okay, so what is the name of this substance? This is a pretty easy question here. This is called Vernix caseosa. Vernix caseosa. Okay, and this Vernix caseosa is common in full term or even post-term baby. Okay, but it is not seen in preterm baby or premature baby. And what is the function of it? The function is it is preventing the heat loss. It is preventing the heat loss from the baby. Okay, so please do not rub it very hard to remove it. When we give a shower or bath to the baby, it will be removed from the body very nicely or easily. Now question number 20, identify the swelling which is present on the head. Okay, and what is the cause of it? Now look at very carefully what type of swelling is this. This is a big swelling which is covering most of the scalp. Okay, most of the scalp. So this is clear cut. Okay, case of Caput succedaneum. Caput succedaneum. We can simply call it Caput also. Okay, and what is Caput succedaneum? It is the edema. It is the edema of scalp. Edema of scalp. And this is very, very common in case of cephalic presentation, when the head is descending down and when the head is covered or surrounded by the cervix. Okay, the rim of the cervix. This rim of the cervix will cause constant compression to the head, which will lead to edema formation there. Okay, so we consider this as one of the normal finding at the time of birth. Yes, it is a little bit concerning if it is very big, but you don't need to do anything there. Within 24 to 48 hours, maximum up to 72 hours, okay, it will disappear. It will disappear. Okay, so no need to do anything there. This is Caput succedaneum. Now, dear students, what is the cause of it? I have already explained to you. This is caused by constant compression of the head, okay, by the cervical rim. The cervical rim is compressing the head, and the head is a presenting part in this case. Okay, and that's how it is present there. Now one more question which is very commonly asked here is, what is the difference between Caput succedaneum and cephalhematoma? Now Caput succedaneum, you can see here there in the picture, the Caput succedaneum, okay, is crossing the suture line. It is crossing the suture lines or the sutures, because it is very superficial, it is in the subcutaneous layer or the space of the scalp, and we all know scalp has got 5 layers. Okay, the first is skin, the second is subcutaneous tissue, the third is called aponeurosis, the fourth is loose areolar tissue, and the fifth layer is called pericranium. Okay, so this caput is present in the subcutaneous layer, so it is crossing the suture line, it is widespread. Whereas the cephalhematoma is present, okay, below the periosteum and above the bone, the subperiosteal area. As a result of this, it will not cross the suture line. It is localized to one of the cranial bone. So memorize it, okay? This is very, very important one. Second, cephalhematoma is a feature of birth injury or birth trauma, especially the instrumental delivery like vacuum. Okay, birth trauma, that is cephalhematoma. And it will not cross the suture line. It will not cross the suture line. Okay, so this is cephalhematoma. And what is the treatment now? The cephalhematoma, though there is a collection of blood here, you don't need to do much. You don't need to do anything. That's what I'll suggest here. Okay, no need of any incision, no need of any drainage. If you do that, you will cause more harm to the baby than help, because you may introduce the infection there, so don't do that. Okay, so it will disappear slowly. It will take around 6 to 8 weeks, okay, to completely disappear. And one of the problem of this cephalomytoma is it may aggravate the neonatal jaundice sometimes. But if that occurs, we have a different treatment here, isn't it? We can take the baby for the phototherapy. Now, number 21, which sign is this, which is shown in the picture? Very, easy question. This sign is called capillary refill time, CRT, capillary refill time. And dear students, in a newborn baby, the capillary refill time is usually less than 3 seconds. Okay. So what are the causes of abnormal sign? Abnormal sign means prolonged capillary refill time. Okay, prolonged CRT. And if this question is asked, you can clearly say hypovolemia. Hypovolemia, okay, is the most important cause. And some of the causes of hypovolemia you can say, yeah, right? Like, diarrhea, okay, fluid loss from the body, any bleeding, these are some of the important causes. And another one may be hypothermia, which will cause vasoconstriction. So these are the multiple causes you can write here. Okay, so hypovolemia, excessive bleeding, okay, increased bleeding, hypothermia, these are some of the causes, or even shock. Okay. Now number 22, what abnormality is noted here? Now, you can see this baby is breathing with a lot of difficulty. How do I know that? Look at this area here. Okay, this is called indrawing of the chest. Indrawing of chest. Now, indrawing of chest is one of the very severe features of respiratory distress. This is called respiratory distress. Okay, and the question is, what are the features of respiratory distress other than indrawing of the chest? So you will write indrawing of the chest once again here, okay, which is followed by nasal flaring, head nodding. In a very small and premature baby, head nodding may occur. Then subcostal and intercostal retraction, okay, intercostal retraction, okay. And in another one, in a relatively bigger baby, we can also see sternocleidomastoid and trapezius are contracted, or they are in use. And one more you can write, okay, there will be cyanosis, there will be bluish discoloration. But frankly speaking, cyanosis is a feature of respiratory failure rather than respiratory distress. Okay, so these are some of the very catchy questions. Now another one, see this, identify the sign which is shown here. The sign which is shown here, see this hand is blue, okay, this hand is blue, but the lips are still pink. So this is a case of peripheral cyanosis, and we call it by the term acrocyanosis. Acro means peripheral part of the limbs. It is acrocyanosis. Okay. So what are the components of the Apgar score? Acrocyanosis is very common at the time of birth because of the temperature difference, and that will cause vasoconstriction. So acrocyanosis will occur, but after a few hours, when the baby is warm, this blueness will disappear. So what are the components of the Apgar score now? A, P, G, A, R. A for appearance. P is pulse. Pulse is known by heart rate. G is for grimace. A for activity. And R for respiratory effort or respiration. It is not respiratory rate, okay? It is respiratory effort. So maximum score is 10, maximum score, minimum score is 0. If it is more than 7, it is considered normal, okay. If it is 4 to 6, okay, it is considered mild depression or hypoxia, and less than 3 is called severe hypoxia or severe respiratory depression. So these are some of the important points there, students, which will be asked from here. Okay, so with this let me stop here for today. The video is already a bit longer, okay, and I'll continue to post videos like this to help you. I'll be very happy if this type of discussion will help you, and I want your feedback, okay, regarding this. Thank you.